Good evening, or good morning, or good afternoon, everyone, from everyone across the world, and welcome and joining us on our ISSM webinar today. This will be a joint session between the ISSM and the MESSM societies. Our topic today will be from diagnosis to recovery, integrating sexual health into the cancer care pathway. Just an important point before we get going is we do have the option for translations if you want to do this in your language of choice. As you can see on the screen here, you can go to the Show Captions button beside your Q&A on your toolbar there, and then you can choose your language of choice. So if you want to set that now, please go ahead. Just an important reminder of the ISSM's vision. This is because every human being has the right to a healthy and satisfying sexual life. And then also our ISSM mission and purpose, which is to become the most respected and trusted source for information, education, and professional development in the field of human sexual health. We achieve this through world-class publications, research, online and in-person opportunities for knowledge exchange worldwide, and has been around for about 50 years now, since founded in 1978. ISSM is affiliated with multiple societies across the globe. We have the MESSM in North America, SLAMS in South America, the European Society, we have the Middle Eastern Society, the African Society, South Asian Society, and the Asia Pacific Society. So well-represented group from across the world. And ISSM has joined as well. And then just a reminder of the various journals and academic resources available through ISSM, the Journal of Sexual Medicine Open Access, the Sexual Medicine Reviews, as well as the video journal on sexual medicine.
Thank you, everyone, and thank you for the ISSM for the collaboration in this important educational activity. I am Mohammed Arafa, Secretary General of Middle East Society of Sexual Medicine. Actually, for the past few years, we are doing extensive educational activity. Just in July, we have just finished a cadaveric course in Amsterdam. We are doing one on oncosexuality next week. And then we have the 6 weeks of our famous penile implant summer school, 6 weeks of online course of never-ending videos on penile prosthesis implantation and its complications and everything regarding it. In September, we'll have another masterclass in Beirut and the sexuality in menopause webinar. In October, we're having the penile curvature masterclass, and it will be hands-on in Cairo, Egypt. And in November, we have another penile implant masterclass. It was supposed to be in Muscat, Oman, but recently it changed to Tunisia. And we have rare male sexual disorders webinar. In December, we have our main event, which is our Congress, which will be preceded by a lot of pre-Congress workshops, like ultrasound workshop, 2 penile implant workshops, one of them cadaveric, the other will be on the hydrogel models, psychosexual workshop, and urethral reconstruction workshop. Next, please. And we invite you all to join us in Qatar, in Doha, in December from 11th to 13th, to attend our 9th annual Middle East Society of Sexual Medicine. I assure for you that it will be a marvelous event. The weather is the best at that time. You have the warmth in the morning and the slight chilly weather in the evening. We have a very rich program, 1 pre-Congress day and 2 Congress days full of discussions covering all the disciplines of the sexual medicine. So please join us in Doha. Thank you very much. Nahid, the floor is yours.
Thank you. And just to introduce myself, I guess I mentioned earlier, my name is Nahid Panjani. I'm a urologist at the Mayo Clinic in Phoenix, Arizona, and had the pleasure of moderating today's session. So we have an exciting panel up with 3 talks today. The first talk will be on sexual health counseling at urologic cancer diagnosis, communication strategies, and prevention of treatment-related complications by Mohammed Marzouk Abdallah from Egypt. We'll then follow this by a talk by Christian Nelson on maintaining intimacy, psychosexual, and couple intervention in cancer care. And then our final talk will be sexual health counseling at gynecologic and breast cancer diagnosis, communication strategies, and prevention of treatment-related complications by Faisal El-Kak. And then we'll proceed to the Q&A session. Just a point about the Q&A session, it'll be our preference if you can use the Q&A button for questions that you have. And then it'd be really helpful and important if you can address the speaker to whom your question is for. This will help enrich our discussion and allow us to make sure that the right person is answering the right question. But I believe the chat feature is also available if you're having technical difficulties with Q&A. But like I said, Q&A is our preference. And then just a reminder that this will be recorded session, and so it will be available later on, I believe tomorrow on the ISSM website. Looking forward to an exciting panelist today, and I guess we'll move forward with our first speaker.
Good evening. Thank you, Nahid, for the nice presentation. I am Professor Mohammed Marzouk from Egypt. I am a senior consultant at Sultan Qaboos Comprehensive Cancer Center at Muscat, Oman. My talk today is about communication strategies and sexual health counseling at the point of urologic cancer diagnosis and the prevention of treatment-related complication. Next, please. I have no financial relationship or conflicts of interest to disclose, and this presentation is intended for educational purposes and don't constitute personal medical advice. Next. Our objectives today is to understand the basic impact of urological cancer on sexual health, learn practical communication skills, and identify immediate prevention solution and management of oncological treatment complication. Next. There are 6 guiding principles for sexual health in cancer survivorship. These guidelines are incited from a nice paper titled Guidelines for Sexual Health Care for Prostate Cancer Patient Recommendation of an International Panel. I am pleased to acknowledge my colleague and co-speaker, Dr. Chris, who is one of the authors of this nice paper, and his work has informed this talk a lot. These guideline principles include the first one is a healthcare provider should be proactive and looking for health problems in cancer patient treatment. Also, the sexual recovery procedure is a multidimensional, including biopsychosocial dimensions, and the healthcare provider should look overall for all these dimensions. Grief and mourning in recovery must be acknowledged by the provider and help the patient during the process of recovery. And we should ensure for the patient that there is no return to the baseline, and the partner inclusion is ideal after permission of the patient. And all these processes should be done in multidisciplinary team approach. Next, please. What is the impact of urological cancer on sexual health? Next. The cancer and the different modalities for the treatment has a direct impact on sexual health of the patient of cancer. If we go for the surgery has an immediate and direct effect on sexual health of the patient through nerve damage, through removal of the hormonal secreting organs, through anatomical changes, a change in body image issues. And this is obvious in radical and cystectomy and prostatectomy. While radiotherapy aiding the fuel to the fire of aging, leading to increased fibrosis, vascular damage, hormonal disruption, neuropathy. This may lead to vaginal stenosis and erectile dysfunction. Endocrine therapy, like androgen deprivation therapy for prostate cancer, has a direct effect on libido and erectile dysfunction in males. The chemotherapy, systematic chemotherapy, causes gonadal toxicity, systematic inflammation, neuropathy, and fatigue. This may lead to premature menopause and erectile dysfunction. While immunotherapy and stem cell therapy, both of them include using systemic therapy and whole body irradiation that may lead to endocrinopathies, systematic inflammation, fatigue, endocrine, and prolonged systemic weakness. Next, please. The diagnosing sexual dysfunction in cancer patient involves a comprehensive and multidisciplinary approach. It requires assessing physical, hormonal, psychological, and relational aspects to identify underlying causes and inform management strategies. Next. The expert panel of the American Society of Clinical Oncology believes that introduction the topic of sexual function should be held with the patient alone, with the option of later partner inclusion if desired by the patient. Discussions should be concurrent with the patient literacy level, culture, religious beliefs, and sexual orientation. This discussion should be offered at various points of treatment and survivorship to assess or address any changes. Next. The first part of diagnosis is a detailed clinical history, including personal history and cancer history, including type, stage of the cancer, and the treatment modalities that the patient received. Next. The psychological history should involve relationship dynamics and the partner involvement, emotional challenges like anxiety, depression, or fear of intimacy, sexual history, culture, or personal beliefs about sexuality. To remember, you must ask about sex B's, partners, practices, past history of sexually transmitted disease, protection from sexually transmitted disease, pregnancy plans, plus trauma, violence, and support to sexual minorities. Next. The presentation of the patient as we learned from the guiding principle, it should be multidimensional and include the whole biopsychosocial aspect of the patient. You should ask about genital pains and discomfort like vaginal pain, dryness, sparonia, penile pain, loss of organs. Next. Reduced genital sensitivity is common after chemotherapy or pelvic nerve damage during prostatectomy. Erectile dysfunction is commonly after either radiation or chemotherapy of prostate, and orgasmic disorders. Next. There is a wide variety of ejaculatory disorders that we should look and ask for the patient about: the anorgasmia, anejaculation, premature ejaculation, delayed ejaculation, painful ejaculation, and climacturia. Next. Testosterone deficiency is one of the side effects of the androgen deprivation therapy, and we should look for testosterone deficiency after too early morning testosterone levels that return with a level below 300 nanogram per deciliter in symptomatic men. While vaginal and penile shortening is a quite common presentation after radiotherapy or after prostatectomy in men. Next. Hormonal and metabolic symptoms in the form of reduced libido, hot flashes, and sweats associated with hormonal therapies like aromatase inhibitors or androgen deprivation therapy, and premature menopause in females after chemotherapy. Next. We also look for psychological and emotional symptoms, a wide variety of anxiety and depressions, body image issues, fear of pain or injury, and guilt and relationship strains. Next. The relation symptoms in the form of avoidance of physical or emotional closeness due to embarrassment or fear, strain on the partner due to lack of communication or mutual understanding, and sexual avoidance. Next. After thorough analysis of the presenting symptoms of the patient, we should go and do the physical examination, ordering lab tests and imaging study. One of the important tools that we have in our arms in diagnosing sexual dysfunction in cancer patient is the patient-reported outcomes. Next. We have a lot of tools that can report the patient-reported outcome. It includes the International Index of Erectile Function, Sexual Health Inventory for Men, Erectile Dysfunction Inventory of Treatment Satisfaction, Self-Esteem and Relationship Questionnaire, Sexual Distress Scale in Men and Prostate Cancer, Peyronie Disease Questionnaires, and the Female Sexual Function Index. Next. We should ensure that the guiding principle that we, in diagnosis of sexual dysfunction, it should be in the context of multidisciplinary collaboration between specialties that concern the patient to complain. We should involve gynecologist, urologist, oncologist, psychiatrist, psychologists, and sex therapist, because it is a multidisciplinary approach. Next. However, the diagnosis have many barriers and obstacles. Barriers from the clinician perspective and the barriers from the patient perspective. From the clinician perspective, it includes feeling inadequately trained or insufficiently skilled, limited awareness of the effective interventions, lack of time, lack of privacy, and concerns about making the patient feels comfortable. While barriers from the patient side similarly include concerns about making the physician feel uncomfortable, embarrassment about the topic, believe that the clinician is responsible for raising the issue, and believe that their sexual health concerns are not valid or are an expected and untreatable complication of their disease and its treatments. Next. So communication matters, and the communication ensures diagnostic accuracy. It improved safety, improved functional status, improved emotional well-being, and ensure patient adherence and patient satisfaction. Next. How to improve our communication with the patient. The patient-centered care requires find the problem and fix it. And this is the first guiding principle that the health provider should be proactive. We should educate, ask, tell, ask technique. It is a back and forth cycle between the patient and the health professional that addresses 4 essential components of counseling. It addresses the patient perspective, information that need to be delivered, response to the patient emotions, and the recommendation by the professional for the patient. Next. Communication is a learned skill that requires practice and experience. It includes engagement, empathy, education, and enlistment. Next. Effective engagement involves building rapport and understanding the patient perspective. Start by introducing yourself and greeting the patient warmly. Maintain eye contact to show that you are listening and engaged, and encourage the patient to share their story by asking open-ended questions. Next. Empathy involves understanding and acknowledging the patient feeling and experience. Acknowledge the patient physical presentation and notable characteristics. Listen attentively to the patient story, including their feeling, values, and thoughts, and reflect back your understanding of the patient concerns and experience. Next. Enlistment involves inviting the patient to collaborate in decision-making and treatment planning. Acknowledge the patient's internal beliefs about their condition, including cause, solution, and meaning. Tailor the treatment plan to the patient habits and routine, keeping it simple and manageable, and identify and remove any obstacles that may hinder the patient's adherence to the treatment plan. Next. How to prevent cancer treatment-related complication. Next. As a guiding principle, we talked about it should be multidimensional. We should look to the patient biopsychosocial dimensions all over the process of the treatment, starting from the pre-treatment, during the treatment, early after treatment, and follow-up of survival. In pre-treatment counseling and risk assessment, we should ensure that baseline sexual function assessment using the patient-reported outcome tools. We should have informed consent from the patient, ask about fertility and intimacy planning, and all of these should be done through a multidisciplinary team. This will ensure set the expectation of the patient, reduce psychological burden, and improve treatment satisfaction. Next. During the treatment, we should ensure to have the principles of oncological principle ensured, and try to preserve sexual function without jeopardizing the oncological principle. If you are going to do surgery, it is better to go for nerve-sparing techniques, minimally invasive approaches like robotic assisted to reduce the trauma, benign clitoral preservation strategies, and intraoperative neuromodulation. Next. In radiotherapy, try to use new modalities for image-guided radiotherapy and intensity-modulated radiotherapy to minimize radiation to neurovascular bundles, vagina, and the penile bulb, hydrogel spacers to protect the rectum during the treatment of the prostate. In chemotherapy and hormonal therapy, we try to use less gonadotoxic agent when possible, and adjust doses or schedule to minimize long-term sexual side effects. Next. Early rehabilitation during or immediately after the treatment is crucial to promote sexual health for the patient and encourage the patient to use his sexual health early as you can. In male patient, encourage using phosphodiesterase E5 inhibitors early after surgery or radiation. vacuum erection devices to promote oxygenation and reduce fibrosis, and the benign injection therapy or intraurethral aldosterone if phosphodiesterase E5 inhibitors fails. In female patient, topical estrogen therapy or non-hormonal lubricants, pelvic floor physical therapy to manage dyspareunia, and dilator therapy post-radiation or pelvic surgery to prevent vaginal stenosis. Next. Psychosexual and partner-based support. I think my colleague Chris will address this better than me. It is better to go for sexual counseling or therapy, couples therapy, and support groups. Next. Integrated technology and AI. AI-powered tools is a good tool for the armamentarium of both physician and the patient to monitor symptom and personalize interventions. Telemedicine platforms offers to deliver psychosexual care, especially for remote patients, and apps and virtual coaching for intimacy training, pelvic health, and relationship counseling. Ongoing follow-up and monitoring is essential to ensure the patient healthy life. Periodic evaluation using sexual health scales, adjust therapies, change antidepressants that affect libido, and monitor hormonal levels and bone health in long-term survival. Education and training. Train healthcare provider in sexual health communication. Use decision aids to help patients with quality of life outcomes, and develop guidelines on managing sexual complication post-cancer. Our take-home message: communication matters. Enhance diagnostic accuracy. It promotes patient safety, improves functional outcomes, supports emotional well-being, increases treatment adherence, and boosts patient education. Effective clinician-patient communication is not optional, it is therapeutic. The principle for sexual health in cancer survivorship includes proactive provider role, consider multidimensional sexual recovery, acknowledge grief and mourning in recovery, no return to baseline, partner inclusion is ideal, and multidisciplinary team approach. Healthcare provider should undergo sexual health using case-based reflective learning approaches, adopting a biopsychosocial models, and incorporating attention to ethnic and racial diversity and to sexual minorities. Thank you.
Thank you for a fantastic talk on aspects related to counseling. We'll kind of continue the conversation with Chris Nelson, who'll talk about maintaining intimacy, psychosexual, and couple intervention in male cancer care. Chris, floor is all yours.
Good evening, good afternoon, good morning, whatever part of the world you're from. Thank you for having me. I want to thank Mohammed for a great talk, really important information and good information. I learned a lot. And so I'm going to talk about maintaining intimacy kind of in the midst of cancer treatments and the impact on sexual functioning. I'll focus primarily on men. I know Faisal will focus some on women after this. And so, but most of my work is done with men. And so next, please. So I have no financial disclosures related to this talk. I do just need to highlight some United States National Institutes of Health grants that I have for some of this work. Next. So why psychosocial interventions? Why is that important in this group of patients who, after cancer treatments, are experiencing sexual dysfunctions? Next. Primarily because, well, sex is complicated. And, sexual dysfunctions and treating sexual dysfunctions is different than something like diabetes because of because ultimately, and Mohammed talked about this, we want to take a biopsychosocial perspective. And next slide, please. And this really kind of maps out the biopsychosocial perspective that, when we think about what we can do from a biological perspective, kind of what are the medications that we can give to help treat sexual dysfunctions, that's certainly an important piece. But really kind of the psychological, what's happening on the individual psychological level in terms of performance anxiety, whether it's impaired self-image, depression, trauma, sociocultural, from a cultural perspective, how does that impact someone's ability to talk or discuss or bring up sexual concerns or sexual problems with their doctor. And then, of course, interpersonal. If you're having sex with someone else, it's the quality of the current relationships. It's actually quality of past relationships might impact this. And so all of these things interact to produce and help people with sexual satisfaction. And really, when we think about psychosocial interventions or psychosexual interventions, it's thinking about kind of the perspective of this model just in general as how we can best help patients. Next. So we've heard about the impact of sexual problems and actually the impact of cancer treatments on sexual problems, but how about the impact of sexual problems after cancer treatments, and what does that have on patients? Next. And ultimately, kind of this is what one of my patients said. He said, sex used to be fun. And this was something that ultimately from many perspectives, they didn't necessarily need to think about it. They didn't need to think about their physical response in a sexual situation. They knew that things like potentially like their erection was going to be good. They knew that they were going to have an orgasm. They knew what it was feel like. They knew where they were going to ejaculate. They weren't necessarily worried about leaking urine, either at foreplay or at orgasm. And all these things come into question after cancer treatments when you're having some difficulty with sexual problems. And so this notion that sex used to be fun. Next. And what's the impact of men in terms of these sexual dysfunctions? Here's what I hear men say about the impact of sexual dysfunctions. And so what I did is I was just in clinic one day and just wrote down all the phrases and words that I heard. And here are just a few of them. So men describe this as soul crushing. So men who experience something like erectile dysfunction after cancer treatments, they talk about it as just as a core of what it is to be a man and how crushing it is for them. They describe themselves as broken, as deflated, as inadequate, terrified to enter into a sexual situation. And interestingly, they discuss and talk about themselves as different than other men. So I'm in New York City at Sloan Kettering Cancer Center. And so men will talk about they walk down the streets of New York City and they know that they're different than other men if these patients are experiencing something like erectile dysfunction. Next. And so we know there's a number of different studies. We know now that the impact of something like erectile dysfunction is associated with depression and depressive symptoms. And so we've seen really good population-based studies in the United States and South America, and Europe and Asia, really mapping out this association between erectile dysfunction. And here I even have Peyronie's disease as PD is associated with depression. And what you see is rates of about 50% of men who experience either erectile dysfunction or Peyronie's disease. 50% of men who basically are experiencing depressive symptoms enough that they would warrant evaluation. Also, ED and Peyronie's disease, you think that bother doesn't dissipate. Often what men hear is something like, well, you just get used to it, you'll adjust. But the bother related to these conditions doesn't dissipate. We've actually looked at data right after treatment for cancer where bother for ED jumps up, and then we followed that out to 2 years, and it stayed pretty much exactly the same over that 2-year period. It really doesn't seem to dissipate. And we know also that this can feed into to have relationship difficulties or relationship troubles. And even men after treatment for cancer, men who have had problems with their erections and they recover erections, even for those men who recover their erections, they report a decrease in sexual satisfaction. And so it's not only the impact on erections, but it's the impact on all the other things too. Again, their ability to ejaculate, how does their orgasm feel? If they're leaking urine, if they've had penile morphology changes, all these things add up to impact men. Next. And so we do know we can help. We know we have some good treatments, especially for erectile dysfunction. Next. And so we know these treatments, right? Pills, penile injections, vacuum devices. I have Muse here. I know probably most people don't use Muse, but that is an option, and then penile implant. And actually we can help patients with this. And so really, if you go to the next slide, what's the problem? Like, why is this, with all our treatments, why is this such a concern? Next. And this is a quote from one of the US Surgeon Generals, is that drugs don't work in patients who don't take them. And then if you can go to the next slide, the idea is, what unfortunately happens is men avoid and drop out of ED treatment. And we just see this kind of over and over again. Next slide. And so here's some of the data on avoidance and dropping out of ED treatment. So if you think about PDE5 users, only 50% of those who are prescribed a PDE5 renew the prescription. Injection users, only 50% of injection users continue to use injections after a year. If you look at some self-report data we collected in terms of injection use, only 60% continue after 4 months, and only 33% use injections at the rate suggested for rehabilitation after prostate cancer treatment. If you look at a syringe count, which is an objective measure, we know how many syringes we prescribe, and then we ask them how many they have left, and we know we can do the math and figure out how many they've used. So only in terms of how many times are they injecting a week, it's less than 1 time per week, and only 10% at the rate suggested by rehabilitation. And so next slide. This really led to some research and thinking about kind of why is it that men avoid, and this is from some of my qualitative work where we worked with 8 to 10 men in about 4 different qualitative groups, our focus groups, and ultimately this is what they described: the cycle of frustration and avoidance. And that is, there's disappointment, shame related to erectile dysfunction, and we've talked about that. Then what that triggers is a fear or anxiety of entering into a sexual situation. They have a fear that their erections won't be firm enough. They talk about the whole process as humiliating. Anytime we're anxious about something or nervous about something, that leads to avoidance. And so this leads to men avoiding sexual situations, avoiding things like ED treatments, leads to a loss of valued life experience. And this just increases frustration, distress, and depression. Next. And this leads to what is one of my favorite slides. And so this is a stereotype. And I just want to focus on the top. The stereotype is for men. Men are always in the on position. They're always ready to go, right? That's the stereotype. I would say that if a man has difficulty with erections or other sexual dysfunctions, that man actually may be in the off position. He may be avoiding sexual activity, avoiding the use of these treatments, and it's a psychological process. Next. Which led me to develop an intervention for men following radical prostatectomy. Next. Which ultimately used a type of psychotherapy called acceptance and commitment therapy, which I call ACT-ED. And really what we do is focus on coaching. We explore the importance of sexuality. We talk about accepting short-term anxiety for long-term goals. We hopefully diffuse anxiety and frustration. We discuss barriers, and we really focus on a commitment. Next. And we've tested this in a smaller randomized controlled trial. This is a larger randomized controlled trial. Ultimately, it's randomized between injection training and our ACT intervention, or injection training plus a nurse practitioner enhanced monitoring and education communication intervention. Essentially, both interventions last for 12 months. There's 3 individual sessions and then basically 10 boosters over the 12-month period. Next. And what we can see, and these are some of the preliminary analysis and preliminary results, the ACT-ED group here is the intervention group, the EME, which is the enhanced monitoring education, is the control. And we can see in the ACT group, they're injecting more frequently in terms of median weekly injection use. They're at least almost 1 injection per week higher. And then the adherence, that is the rate that was suggested for rehabilitation, is almost twice as much as in the ACT group. And so these are good data which suggest things like psychosexual approaches, and this is an approach specifically to address avoidance of sexual activities in using ED treatments, can really be effective. Next. Other interventions in this area are really mindfulness approaches, and Lori Brado in Canada and her group have really pushed forward and tested mindfulness and mindfulness-based cognitive therapy. in randomized controlled trials to help reduce anxiety during a sexual situation. And so you think about the intervention I just talked about as a way to help reduce avoidance to sexual situations. These would be interventions to help reduce anxiety and try to improve pleasure and enjoyment within a sexual situation. And so these interventions can be very effective as well. Next. And then, so those are kind of interventions for the individual. In terms of relationship aspects, next. So we can think about a couple dynamic, and this is really working with men with ED, and you think impact of ED on the man, right? That's kind of where this might start. Distress, the patient is saying, I don't feel like a man. The patient might think my partner will leave you. And that person, that man, if it's a male, he's taking a male perception of sex. And then the impact on the partner. Oftentimes what happens is anxiety in sexual situations translates or passes on to the partner. The partner, if it's a female partner, she becomes more anxious. She might feel the man withdraw from intimate situations. I just talked about avoidance, but and there's sometimes an active withdrawal from intimate contact or intimate situations. And so there can be an anxiety that goes back and forth, but ultimately what happens a lot is the partner tries to be supportive, and ultimately the partner may say something like, it's really okay. Something like, your erections aren't the most important thing to me. What's most important to me is that you were treated for cancer, you're alive, and there's other things we can do in a sexual experience. And she's taking a female perception of sex. And then the male perception of sex, when you ask men what their favorite thing is, what they enjoy most about sex, they'll say something like penetration's number one. What's number two is penetration's number two. And then what's number three? Well, penetration's number three. And the female, when you ask women what kind of their favorite thing is about a sexual situation, oftentimes they'll say things like it's the closeness, intimacy, together, the foreplay. Penetration might be on the list, but it's lower. And what happens is they start to discuss and talk about these things just on different planes. And what's helpful is working with something like a psychologist, a mental health professional, a sex therapist, a social worker, who can help couples talk about these different perspectives and try to come to some common ground. So this leads to the disconnect between the couples. I call it like a he said, she said, and ultimately brings out distinction between sex and intimacy. And the importance is to educate, facilitate discussion, refer to psychologists or couples therapists. Next. So this is a strategy too that's often used, which is sensate focus, which is focusing more on things like caressing, not worrying, or the goal is not an erection, the goal is not orgasm, but there are certain steps here for sensate focus. I'm going to move on just for time's sake. Next. And often talking about, with couples, restarting sexual intimacy, focusing on the pleasures as opposed to performance, creating a safe space, trying to be specific with one or two ideas that want to change or do something different, focus on the positive, using nonverbal sexual communication, try to avoid arguments, discuss their fears, take time to listen, and go slowly. Next. And so resources for sexual medicine clinician. Now, these first resources are in the United States. I know they don't apply all over the world. In fact, they only apply in the United States. But I put this up here as examples. And you might look in your country, in your specific area, for these types of resources. In the United States, there's STAR, which is Society of Sex Therapy and Research. And there's the American Association of Sexuality Educators, Counselors, and Therapists that may be similar to what happens in your community. Yeah, thank you. Great. Yeah, so the websites are listed there, kind of in the chat. So the other important thing is, in your practice, if you can develop a capacity, reach out to mental health professionals in your community, whether it's sex therapists, psychologists, social workers, counselors, and actually reaching out and establishing those connections and really being proactive is important. Next. And so in summary, why psychosexual and couples interventions? Well, we're going to take a biopsychosocial approach. Distress is related to sexual dysfunction. We see that in men, and these types of approaches can help. Hopefully it can help address avoidance to treatments and sexual activity, and hopefully it can help relationship dynamics. The notion is to assess and refer and establish a connection with a mental health professional in your community. Next, and I think this is my final slide. This is actually my favorite slide. But this is actually like a supermarket in the United States, and it's supposed to say, "Pen is broken, please use your finger." It has exclamation point, but really what it says is, "Penis is broken, please use your finger." And you know, we can help men. Men don't necessarily want to use their finger. We can help them, but oftentimes working with a couple, we can see if they kind of use whatever they need to use, whether it's a penis, a finger, or other aspects of sexuality. Thank you for your time.
Thank you for that fantastic talk, and I'm looking forward to discussing this more afterwards. So we'll go to our final speaker today, and we'll talk about sexual health counseling at gynecologic and breast cancer diagnosis, communication strategies, and prevention of treatment-related complications. I'll take the floor over to you, Faisal.
Thank you very much. Thank you for the previous speaker. I also want to thank my friend Elisa and ISSM for the invitation to this webinar. Hello, everyone. I'll be covering something which is really marginalized most of the time, which is the impact of cancer and cancer treatment on female survivors. Next. I have nothing to disclose. Next. Well, we'll look together at the burden of the GYN cancers and how they impact and why the sexual life and performance of female, and what can we do about that. Thank you. Next. Well, I think in medicine in general, and in specific, in issues of sexuality and sexual health, we are trapped into the Bermuda Triangle of medicine. Why is that? Because one, there is a lack of knowledge around the impact of cancer and treatment, diagnosis, short-term, long-term, on female. There is lack of effective care because either there is lack of competence, lack of skills, or lack of time. And there is also, which is really serious, lack of empathy. Many of the complaints raised by cancer survivors are being gaslighted. Next. And this is happening at a time where there is a growing incidence globally, as you can see, of the cases of cancer. In 2022 alone, there was around 40 million new cases with around 1.4 million dead from 6 female cancers: breast, vulva, vagina, uterus, and ovaries. Next. And looking more carefully at these numbers, you can see that the incidence and the mortality are quite similar between males and females. And more than that, the prevalence in females is going to be higher than males for the coming 5 years. So we're really facing a different demographic and prevalence dynamic in relation to cancer. Next. And when you think about why is that? Because cancer treatment, whether it is surgery, chemotherapy, or radiation, together or alone, can impact changes in sexual function, in addition to confounding factors, as you can see, related to hormonal disruption, reproductive failure, moral bladder, extent of surgery, and short long-term sexual mobility. And how is that? Because, for example, chemotherapy leads to ovarian toxicity, radiation leads to stenosis, fibrosis, endocrine therapy will end up in genitourinary syndrome of menopause, and surgery, of course, will lead to disfigurement and nerve damage. Next. Many papers, many landmark papers, and societies have shown the impact of cancer on sexual function and dysfunction. In this interesting paper from Harvard, female cancer survivors endorse at least one distressing symptom related to female sexual dysfunction, dyspareunia being the most common one. The American Cancer Society urges to put more attention to survivorship issues, including quality of life and the consideration for the management of the late effects of treatment. And they were both related to survivorship characteristic, and also to the type of the treatment. Next. Additional papers have shown, again, dyspareunia can go up to 45% or more in the survivors, while those, for example, treated for the head neck cancers, which is not a GYN cancer, but again reported loss of interest in around 35%. Another review looking at 35 studies, taking into consideration the cancer types, the sites, the stage, and the intervention, has shown a drop in the female sexual function index to less than 20 at all cancer sites, whether it is a GYN or breast, with the prevalence of female sexual dysfunction that can reach 100% at all cancer sites. Next. So there is really a major issue that we're talking about. This is a systemic review from the University of Wisconsin of Madison, looking at all the concerns. So again, putting this within the psychosocial profile. Looking at the physical concern from dyspareunia to decreased satisfaction, pleasure, sexual activity, anorgasmia, urinary and bowel problems, postcoital bleeding, to the psychological concerns, whether it is about feelings, about anxiety, about body image, about perception of decreased femininity, about the fear of transmitting cancer to the partner, and the social concerns about the expectations from the role, about the expectations from emotional intimacy, about reaction to the change, the perception of the partner that his partner is not attractive anymore, is not sexual anymore, and so on and so forth. So you have a combination of different aspects that really interfere in the overall impact on the sexuality and sexual function. Next. And despite all this, I find this really very, very bothering. Despite all of these data and facts, 74% of the long-term GYN cancer survivors believe that the physicians who are supposed to raise the questions, who are supposed to give the advice, they stated in 64% of them that they never initiated a conversation during their care. And if this is not gaslighting, then what it is? This denial of sexual health and sexual function and sexuality and intimacy in a situation where cancer and the treatment of cancer is going to affect mostly this aspect of our well-being, and still it is not addressed. Next. This is a recent article from the European Network of Young Gynecological Oncologists, again saying or concluding, and this has been done in 46 countries in Europe, showing that 21% of respondents only try to gather information in the clinical interview, while other 20% never discuss the topic. And that's now, and that's in Europe. Another one published in the Journal of Psychology and Oncology, again, show that only 20% did ask about sexual health and sexual function, although they know that at least 50% of their practice are patients who are complaining of this problem. Next. That's why this seminar is very important, and this kind of discussion is really essential and timely. So the approach in this case is really depending on a model that has to do with chronic diseases and the outcome. And in this model, there is a strong relationship between chronic disease and sexuality and the quality of life through the impact of disease and the impact of the treatment, and also through limitations and disability within the context where culture, values, faith, and relationships play a role. Next. This is one of the really interesting recommendations published recently in the Green Journal, looking at the, again, biopsychosocial approach, focusing mainly and primarily on screening patients for sexual health. You don't have to be a sexual health expert. You don't have to be a sexual medicine expert. It's not a rocket science. It's just about really putting your passion and asking the right question that you are supposed to ask, using validated screeners, and incorporate review of systems. The second step would be identifying symptoms and offer a targeted stepwise approach, whether in diagnosis or in treatment. The third one will be referring to experts based on patients' needs. As my colleagues before me stated, there are the psychologists, there is the psychosexual expert, there is the pelvic floor therapist, there is the gynecologist, the urologist, and also sometimes in some places you have the specialty sexual health clinics, like the one we have at the American University of Beirut. We have the WISH program, which is the Women Integrated Sexual Health, that really takes care of the oncosexology unit within this program. The most important thing is to have a provider who's committed for this, who's competent and is able to overcome the patient-doctor driven barriers. Next. There are many suggestions. One of them is the PLICIT model, which is an office-based model that gives you the legal permission to talk, and you provide the patient with limited information that are very helpful, and it gives you the chance to suggest specific aspects depending on the complaint, and also being able to refer to more specialized care. Another suggestion from Lindo, it's very important. All what's saying in this slide is that you have to anticipate outcomes, like you anticipate physical outcomes, mental, psychological, social. You have to anticipate sexual. And you have to tell the people what to expect. And you have to give time to discuss this. And you have to be able to provide basic care according to the ECHO recommendation 2017, and also be able to share resources with the patient and to refer them to specialized care. Next. We mentioned earlier in the first step of the approach about using screening tools. Well, these are the list of screening tools. There is brief sexual symptom checklist for women. There is a single item also, a screener for self-reported sexual problems. These are very easy. One has four questions, one has one question. And there is the classic FSFI with 19 questions. There is the Arizona Sexual Experience Scale. And there is also the Patient-Reported Outcome Measurement Information System. The FSFI and A6 are good for breast cancer survivors, but for easiness and for those who are pressured with time, you can use the brief sexual symptom checklist and the single item screener. Next. The brief sexual symptom checklist is 4 questions. Are you satisfied with your sexual function? Yes, no. If no, how long have you been dissatisfied? It's a typical question. This is something you have to ask even without having a cancer survivorship or other problems. This is basic medical, surgical, obstetric, gynecological, and sexual history. And then the third question will be, if you have these problems, is it around what? Is it around interest, desire? It's around pain, dryness, lack of lubrication, and which is, among all of these, is the most bothersome on a scale of 1 to 5? And would you like to talk about it with your doctor? You're giving them the space, reassuring them, yes, you can talk about this. The single item screener, asking about the past 12 months, there have been ever a period of 3 months or more when you had any of the following. What are these following? These are wanted to feel more interested in the sexual activity, difficulty with erection for men, vagina felt too dry, pain during sexual activity, difficulty having an orgasm, anxious about sexual activity, didn't enjoy it, or other concerns. 1 or more in this case. Next, please. This is a very recent application from the NCCN guideline for general cancer survivors, which involves the patient and family education about expectations, the physical activity and the importance of physical activity and the scope of the physical activity, the most important interventions from psychosocial to nutrition to well-being, and also the availability of hormonal, non-hormonal, pharmacologic and non-pharmacologic interventions. Next. Exactly in women, we're dealing with 3 major aspects. We're dealing with all the issue of dyspareunia and penetration disorders in heterosexual or even homosexual situations. You're dealing with the genitourinary syndrome of menopause and its symptoms. You're dealing with decreased absent breast and nipple sensation, and overall interest arousal issues. So this is the list of, or the tools, or the medications, or the interventions you might have. In the case of genital syndrome of menopause, you're dealing with low estradiol with ovarian toxicity, you're dealing with dryness, and you need to have vulvovaginal moisturizers. It's available, effective, even comparable to low-dose estradiol. Also, you have the vitamin E, it can be very helpful. You have lubricants, water-based, silicone-based. Of course, water-based is more preferable. And you have the vaginal estradiol cream or the insert like Vagifem. It's very effective. It's recommended even in cancer survivors. It doesn't accumulate in the system. It doesn't cause any endometrial hyperplasia and the scare of uterine cancer or anything. Also, you have the intervention of the pelvic floor physical therapy has been shown to be very effective. In case of radiotherapy and the impact on the vaginal stenosis, you can use the progressive dilatation with the vaginal dilator therapy. And in case of sexual response, interest, arousal, desire, couple relations, intimacy, as my colleague mentioned before, psychosocial counseling, psychotherapy, couple counseling, mindfulness are very important. Also, the new FDA-approved flibanserin for the desire, premelanotide, or the new also mineralocorticotropium type 4 is also approved for the desire. Testosterone, not FDA-approved in the States, much used in off-label in the US, in Europe, and in many other countries around the world. Psychosocial counseling is very important also in case of body image issues. Next, please. This is another recent article showing the effective interventions of managing sexual health in breast cancer survivors. And it really highlights that psychosocial or psychosexual counseling, where there is no preference, they have equal impact in terms of body image distress. Comes to sexual response, whether you are using the DSM-4 or the ISPD, the interest, arousal, or the desire, and other domain of the orgasm and pain. Psychosocial, psychosexual counseling, again, including CBT, is important, and also the sensate focus important, in addition to the treatment of the genital symptoms that has to do with the vulvovaginal atrophy and the related issues that I mentioned before. And also for the intimacy relationships, psychosocial, again, and psychosexual counseling are very effective. It's also recommended that digitally delivered interventions should be kept in mind, especially the CBT. Next. Well, my recommendation is it's very important to acknowledge, to recognize, and to train yourself to learn more about the sexual health problems, to sensitize yourself, to learn the vocabulary, the approach, the sexual health questioning, what to use in your clinic, and to make sure that people living with cancer have serious issues with their quality of life. Also, learn what to screen. You have options to screen, short one, long one. Please do that. Identify the resources recommended to your patient. Identify colleagues with different expertise, and also work with them. And that's very important to ensure the well-being of women, of course, and men and couples in cancer survivorship journey. And thank you very much.
Thank you very much. So now that we've kind of concluded our lectures, we will open up to Q&A. So please, as a reminder, you can use that Q&A button on the bottom there, and you can submit your questions. And again, our preference would be that we indicate the speaker at which your question is targeted to help aid in our discussion. I'll get some stuff started with our first questions that have come up through the Q&A session. One was was already answered by Dr. Marzouk, and I'm not sure if maybe we can just, for the audience, we can go through it. But the question that was asked was by one of our participants, was that intracavernosal injections, or ICI, might have a more rapid penile rehabilitation protocol than perhaps the typical phosphodiesterase 5 inhibitors. Maybe you can give your comments on that question.
Okay, Dr. Nahid, thank you. I think intracorporeal injection after cancer treatment is offered for the patient when BD phosphodiesterase inhibitors fails. And it is quite important to start it early because it helps to reoxygenation of the penile bulb, and also it improves the it keeps the penile length and encourage the intimacy between the couples, and it give a platform for the sexual recovery. So we offer intracorporeal injection when oral pills fails. Or if it preferred by the patient to start an intimacy or a relation with his wife. I think we can also started along with the other lines of treatment.
Could you give a sense of your timeline that you'd want to suggest those interventions?
Timeline?
Yeah, so like after they've had, their cancer treatment, how soon after should we be thinking about such strategies?
I think in patients with prostatectomy, we start early benign rehabilitation as early as we can after 1 to 2 weeks from surgery, or up to 4 weeks, we start the phosphodiesterase inhibitors regimen. If it fails, we start intracorporeal injection for these patients.
Perfect.
Okay.
So we'll go on to our next question, and this is for Dr. Chris Nelson, Dr. Nelson here. So would you agree that they have to work together to really we really have to work together to decrease the dropout rates after rehab therapy by really including the partner in that conversation and that treatment plan and kind of educating both of them versus maybe just targeting the one single individual?
Yeah, for sure. It's a really good point, right? And as much as I can, I try to work with a couple as opposed to the individual, because if it's actually a couple and they're engaging and hoping to engage in sexual activity or sexual relations, right? It's so helpful to have both of them there. And so when you think about the biopsychosocial perspective, right, there's the biological, there's the individual is working with the individual, then there's that interpersonal working with the couple, right? And so clearly there'll be anxiety, kind of that if it's a heterosexual couple, there'll be anxiety that the man has experienced. There'll be cause for avoidance. There'll be anxiety that the female partner is experiencing, which will be cause for avoidance. So the more you can get them discussing and talking together and working with them as a couple, probably the more effective you'll be. It's a great question, great point.
Awesome, thank you. I believe our next question is probably going to be towards Faisal, or actually anyone, actually, really. Does anyone recommend natural oils as vaginal lubricants?
Yeah, definitely not olive oil. Can affect the vaginal environment and increase risk of infection, affects the condom. Coconut might have, in some studies, the latest one in the journal in the Menopause 2020. There is some benefits for the coconut, but definitely go for water-based lubricants. They're available, they're cheap, condom friendly, and they're really very helpful. But if we need to use a natural oil thing, probably coconut, not the olive oil.
I'll ask a question to the group unless anyone else wants to sort of chime in or put things in the Q&A. We talked at the last lecture a little bit about a validated questionnaire or questionnaires that have been validated in cancer populations on the female side. Does anyone use anything in terms of validated questionnaires on the male side in terms of, we talk about the SHIM and the IEF, but these are kind of, typical questions. And so I think sometimes questionnaires both for males and females sort of maybe lack specific questions to cancer recovery, cancer diagnosis, body image, etc. So anyone have any experience in those regards?
I mean, I'll say on the male side, the validation studies have been mainly done outside of cancer, right? And so when you look at kind of those, the IEF, the SHIM, if you think about the SEER or the EDITS, the SEER is the sexual self-esteem and relationship questionnaire. Mohammed had this on his slide. The EDITS is the erectile dysfunction inventory for treatment satisfaction. Those things have generally been validated outside of cancer. And while there's some that have been validated in cancer, they tend to be fairly limited and tend to kind of combine things like function and distress. And so the EPIC questionnaire comes to mind, which in general in cancer is well validated, but there are some questions about how, again, it combines function and distress when assessing things, something like erectile dysfunction. So it's a concern, and I think what we need is actually more validated instruments within cancer asking specific questions about the population. You think like if you look at the IAF, the full IAF, it asks about ejaculate, right, or ejaculation. And we know men after a radical prostatectomy won't ejaculate, it'll be a dry orgasm. And we know men after radiation treatment for prostate cancer, their ejaculate will be reduced, and maybe 1 or 2 years, 3 years after radiation, they won't be ejaculating either. And so it is really important to kind of assess these types of things. I'll just a shout out to Stacy Lowe, who's a urologist and researcher here in New York City at NYU. She's worked together. We worked together as a group to publish a quality of life measure for partners of men with prostate cancer. And so if you're thinking about assessing partners of men with prostate cancer, there's a new validated measure out there, and it's really one of the only measures or assessments of specifically validated for cancer patients.
Awesome. Oh, sorry. Dr. Marzouk, you want to chime in?
Yeah, I want to comment for the validated patient-reported outcome should be measured at regular intervals for the follow-up. It set the expectation before the treatment, and at every step of the treatment, when you change from a line of treatment to another line or end of a stage of treatment, you should re-evaluate the patient-reported outcome tool, whatever it is, because it helps to set the expectation for the patient and ensure patient satisfaction and acceptance of the treatment. Because if we didn't measure the level of sexual dysfunction before starting the treatment or before changing the line of treatment, the patient expectation will change and he will not compliant with the treatment.
That's a great point. So we got a few more questions in the Q&A box here. The next one is, it says HA, which I'm assuming is hyaluronic acid, vaginal injection safe in cancer patients. And
well, it is becoming popular, honestly, and we all know the benefit of hyaluronic acid and the impact of collagen and the reduction of parabasal cells. But there is no consensus yet, Nahid, from the international organizations. Doesn't say they go ahead and use HA, but it's being used. And the longest data we have is probably around 1 to 2 years, and it's safe. But there is no consensus yet. Probably it's safe.
Perfect, thank you.
Yeah.
I guess this question could be for multiple, but any data on the high risk of infidelity once cancer occurs or the risk of divorce? Anyone know of any data in that regard? Depends on what you read, I guess.
Yeah,
yeah,
it's I don't know, like, I don't know if there's data on it. I know that it's certainly one of the fears of men, right? Men who, after cancer treatment, they're experiencing erectile dysfunction. What most goes through most men's mind is my partner's going to leave me, which is a dramatic cause for distress. And really, whether it's a heterosexual couple or a gay couple, when they come to my office and sit in my office, the partner will say, are you crazy? I'm not gonna leave you, right? Like, like my most important thing is that you're treated for cancer. But so I don't know that I don't have any data on it, but I know that it's one of the primary fears of men who have gone through cancer treatment and experiencing some sexual dysfunction. They're very concerned.
Does anyone else have any insight or?
I think I have a comment. I think it is a healthcare provider role to set the expectation and the level of understanding of both couples regarding the cancer effect on sexual health. Because most of the times the patient and the partner has wrong expectation and ideas regarding this, and this may lead to conflict between them. But if we started the discussion early and educate them and show them that the exact expectation, I think this may help to relieve the conflict.
Perfect. We have one more question here. It says, at what time do you raise the subject with your patients?
In our practice, we usually started once diagnosis of the patient of cancer happens, we started to talk about the patient reported outcome, to talk about the what they are really now and what's expected from the treatment, because setting the expectation is more crucial before starting the treatment.
Do you have like a standardized like visit or that happens that, once X person has a diagnosis, do they automatically get seen to discuss this before their treatment, or sort of, I know that in the ideal world we'd say as soon as possible, but what kind of systems do you all have in place to make sure that these conversations are being had and are being in addition to their cancer conversations?
According to the response of the patient, if the patient show interest to be seen by a psychiatrist, or we encourage to involve them early in the process of the treatment, because they help us a lot in setting the biopsychosocial dimensions of the disease.
All right, so Chris, any other comments or thoughts? Your institutions?
Yeah, I mean, I would just say that I agree. I think the earlier the better, right? And we don't, there's, it's difficult to find actually structured, either sessions or additional sessions where this happens. But the hope is that as we just continue to communicate kind of this information, that more and more clinicians are talking about this, before their treatment, before the cancer treatment. Because, Mohammed had just, mentioned that expectations are so important, right? And many times patients come, after the treatment, talk about how they just didn't understand. They just didn't know the impact that these treatments might have. And if you look at data in other types of treatments, not necessarily around sexual functioning expectations, but other types of treatments and expectations, if you look at kind of the notion of expectations make up about 25% of patient satisfaction following the treatment. And so think about that, 25% of patient satisfaction is made up just of proper expectations, as opposed to things of the skill of the procedure, or the skill of the clinician, or how much the clinician is liked and beloved, and all those things. About a quarter is made up of those expectations, which really highlights the importance of talking about this as soon as you can.
Awesome. Well, I think, sorry, we got a long question that just came in here. Someone discussed about the IAF in the context of prostate cancer surgery. We rely on it to help guide decisions, but we lack post-operatively validated thresholds. Are there efforts or interest in developing post-operative scoring systems or treatment algorithms that integrate PROM data to guide rehab or further management rather than just tracking outcomes?
I can chime in on this one if that's right. If that's right.
Yeah, go for it.
So yeah, absolutely. So this actually is it's a really good point, right? That kind of what instruments you asked about this as well, the validated instruments specifically kind of for like sexual functioning after cancer treatments. But it is really important. And so think about the sexual dysfunctions you see for men. So erectile dysfunction is what we hear about the most. It's what we talk about the most. But there's changes in ejaculate. How does that impact kind of the patient and their quality of life? There's changes in orgasm. There's, kind of sexual incontinence, whether it's foreplay incontinence or climacteria. There's penile morphology changes, right? So the penis is shorter, they lose girth, you might have Peyronie's disease. And then there's sexual interest. And so the idea is that hopefully we can develop instruments that take kind of all of those components that you might see that are relatively unique after cancer treatments. I will say that kind of our group has been working on one of these. We presented, I think at AUA, either last year or the year before, kind of some of the preliminary results of a validation study, and we hope to submit for publication soon a measure after radical prostatectomy that tries to include not only erectile dysfunction but these other elements. So I think if we just as a group keep working on this and keep thinking about how we develop these measures and push this forward, I think that's really what's going to change the field.
That's a really great point.
I agree.
We have another question, which I think we've kind of already sort of touched on, which was sort of finding the time to discuss these expectations and setting plans in sort of these environments. And I think we kind of touched base sort of about that, and how, of course, ideally we'd love to do it for everybody, but we just have to find ways to integrate it and make sure the right people who are interested are able to have those conversations.
I agree with
Um,
Dr. Omar.
yeah.
For it needs to be a multidisciplinary. You need to be on your team someone that has time to discuss these sexual issues with the patient, giving the room, giving the time for the patient to speak and show his fears with his clinician.
Awesome. Well, I think that, oh, got one last one coming in here. So while we counsel patients about the possible outcomes, particularly ED, many don't truly appreciate the impact until they experience themselves postoperatively. Is there a structured or evidence-based way to better prepare patients preoperatively, perhaps using tools like decision aids, peer counseling, or immersive education to help set a realistic expectation and improve post-op satisfaction?
So
I think,
I'll just comment. So, the group out of Michigan actually has developed a pre-treatment workshop that happens on a either monthly or every 2-week basis. That is basically a group session, and I think it's done, via Zoom, where patients who are about to undergo treatment can log on. It's specifically designed to talk about the sexual impact of treatments. And so I think a social worker runs it with either a nurse or nurse practitioner, and also maybe a psychologist who works with patients. And so they've developed this structured way actually to try to provide education for patients pre-treatment. It's not, I don't know if it's mandatory, but it's certainly something that all patients who are about to either, have a radical prostatectomy or go under radiation, ADT, it is available to them. And so they've written this up. I think the first author is Kelly, I think it's Page. And so last author is Daniela Whitman. But they have done work out of University of Michigan to really design some educational content prior to the treatment.
Well, that's fantastic. Thank you for sharing that. So we got one more question here. We don't see sexual dysfunction like orgasm in women, but it seems more pronounced in men. And so really it seems necessary that we got to develop some more appropriate tools for screening in women. And I'm sure the panel would probably agree with that.
Absolutely agree.
Yes.
Yeah, for sure. Yeah, I think too, what for men, the notion of talking about sexual dysfunction seems to be normalized more with the advent of PD5 inhibitors. And so, Viagra, Cialis, like those types of things. We now in the United States at least have commercials on Peyronie's disease. And so, tends to be normalized a little bit more in men to be able to talk about these things and seek treatment. And I just don't know that that's happened for women And so I think, I think we just have a long way to go for women. I think we've advanced the field for men some, but not necessarily for women.
Well, thank you all for attending. Thank you to our awesome speakers today for a great session. Just a reminder, this will be available, I believe, by the ISSM online tomorrow. And just to save the date for the World Sectional Meeting, which will be in Portugal in late February 2026. And so thank you all for attending, and hope you all have a good morning, day, or night, depending on where you are.
Thank you,
Thanks,
everybody.
everyone.
Thank you.
Thanks, everyone. Yeah.
Thank you.